guys. Welcome to Podiatry Practice Mastery. Don here. We're going to do this weekly update, and this is part of the how to 10x your podiatry practice. And specifically, we're going to go over the 8 high profit procedures to skyrocket your revenue. So this is what we're going to go over today. Why are these important? Some of these are going to be things that you do as procedures that insurance covers. Others are things that insurance doesn't cover, and so they're cash pay. I'm going to go through some tips on how to kind of explain it to patients, kind of how we got to using these, because I know not everyone uses them, so you might need a little nudge to figure out why maybe you should be using some of these. So high profit procedure number 1 is we're going to go over 8 of these. I'm going to start with my kind of favorite that wasn't always my favorite. It's going to be Shockwave. So when you have Shockwave, I know it can be something, a challenging investment to purchase the machine. We originally weren't doing this a number of years ago until we hired a new associate who now is our partner. And he kind of brought in this idea of using radial Shockwave because all the research in sports medicine and things like that, many people are using. But we were a little hesitant due to the price, and we were wondering if we're going to be able to get our investment back. So let me tell you kind of how it worked with the Shockwave. Once again, we weren't using it. What we were traditionally doing is everything else that everyone does, doing cortisone injections for plantar fasciitis, doing orthotics, things like that. We didn't really have anything great for non-insertional Achilles or insertional Achilles or different tendinopathies. And we decided to get the device, and I think they tried it out. If anyone knows what that's called a puppy dog close. So what you do is when you used to buy wanted to do a puppy, you could take them home and try it. And once everyone tried it, you decide you want to keep it. So what we found out is we found it really worked for our patients with Achilles tendonitis and plantar fasciitis and things like that. How did we originally do it when we brought it to the office? Well, to get used to it, we practiced on each other, and we practiced it on different patients. I think initially maybe we did a reduced fee, let's say $50 or $100, and you would do that maybe for a month, and just so you could kind of get used to it, practicing it on patients, maybe do 3 sessions over a month, just to get confident and making sure you believe in it and seeing results. Okay, that's what we did, just to make sure once you have the confidence, then you can start doing it more. So initially, I think it was maybe $100 a treatment for maybe a month, and so we sent something out to patients. Hey, we have this new treatment. We want to do this, and initially we set up block time, and this block time just made it easier for us to get used to doing it. So let's say Wednesday mornings is when we did all the Shockwaves, and we just had them come in one at a time, one after another, so we can get used to doing the procedures. We had the rep come in. They kind of showed us how to do it. We practiced, and then we started to do it on patients. And then over time, like the price was at $150, and then we increased it to actually maybe $125, then to $150, and now it's up to $200 for the radial. Okay, so for the radial, I can't go into description, but we usually do about 2,500 to 3,000 pulses, 500 intro, and then we zoom it up to like whatever they can tolerate, 3.5 or so. We talk about bars. I don't want to go into the details of what we did, but what I want to go at is that in terms of doing it, you have to believe in it, number 1. Number 2, you have to, if your patients are never saying no, you're probably charging too little. So don't compare with others. Try to make it into a package that they kind of see the value of doing it. In terms of the radial Shockwave, when we only had that for a couple of years, and we had really good results. A couple of wording things that I use, I say radial Shockwave, or Shockwave in general, is about 80% effective, and it speeds up the healing by about 50%. So that's kind of how I word it to patients. There's really no downsides. If they're on blood thinners, you want to avoid the focused, but even with the radial, it's safe to do it on. And they just can't take any anti-inflammatories 2 days before and 2 days after. So that's the radial device. Currently, we do charge $200, and that's pretty much the workhorse for most things that we treat. We do have focused as well. So at one office, we have a radial machine. At the other office, we have radial and focused. And so if we do the combo, we'll charge, instead of $200, we'll charge $250. And then we usually do 1,500 pulses of the radial and then 2,000 of the focused. I personally like to do the focused first because it doesn't make as much noise and I can talk to the patient. And then I'll do the radial afterwards, just because I can talk, because the radial makes a little bit more noise, and we use the earphones and things like that to block the noise. So the focused is a little bit better for penetrating deep, let's say like bone bruises. I'm treating a patient currently with an AVN that didn't want surgery. You can theoretically do it for bone marrow edema, let's say for areas of arthritis. So things that you want to penetrate a little bit more, the focus works better. But currently in my office where I have both, I'll just tend to do both. There's no harm in doing both on everyone. So that's kind of how we do it. And the way we set it up is we do between 3 and 4 sessions initially. One of my partners does 4. I always do 3. I do 3 sessions a week apart. And then I'll do a 2-month follow-up. And that 2-month is when they're going to be going to physical therapy. So I tend to do physical therapy after it. And then I'll do another 3 sessions. The way I kind of explain it, if the pain has been over 6 months, I usually need 6 sessions. If it's been under 6 months, usually 3 is enough. I'm not doing 6 on a lot of people. Some people I've had to do another set afterwards, maybe 9. I've never really done over 9 for patients. People ask me if it's bilateral, do I give a discount? I usually don't give a discount if it's bilateral. I just, unless they ask for it, but usually I'm not doing a discount for bilateral. If I do bilateral, sometimes I'll bring a staff in, so I'll do one foot and the staff will do the other foot. So it just makes it a little bit easier to speed up time. Ways to even make it more beneficial would be to have staff to do the procedure. If you have a staff that you trust in, you could have them do the procedure, have them shadow you every time you're doing it until they feel comfortable doing it. The challenge is a lot of times those patients then have questions about the other things that they're doing. So we still tend to do it, but I could see you could have a staff person do it. So that is a high profit procedure number 1. My biggest key when doing Shockwave is going to be the high profit procedure number 2. So we're going to go now into high profit procedure number 2. So number 2 is using ultrasound. And I'm not saying that the ultrasound is super duper profitable, meaning in terms of revenue. For ultrasound in Massachusetts, where I live and work, usually ultrasound is not covered by a lot of the private payers, meaning it's not that it's not covered, it's covered, but me as a podiatrist, I have to have a special designation or special, they call it training, and have so many ultrasound reads and get almost like a radiologist type of a thing. And we opted not to do that. And so we just say it's not covered. You could go somewhere, but for the most part, we're doing ultrasound guided injections and things like that. So we just do it here, and we charge $100. That's what we charge for we call a limited exam. And if it's more advanced, we charge 150, just depending on like the number of views and things like that we're doing. I'm not going to go into detail about ultrasound, but I've had some questions of how do you learn how to do it. So the same way with Shockwave is you start by having block time, putting all your ultrasounds on the same day. Like let's say once again, Wednesday morning, have everyone come back, ultrasound day, do them all so you can get confident in what you're looking at on the ultrasound, getting confident initially starting with the plantar fascia, then Achilles, then posterior tibial, then peroneals. Then you could get better at doing other areas like soft tissue masses or foreign bodies. But most patients that have soft tissue or foreign body or things like that, they're getting an ultrasound. I tend not to do it the first visit. I tend to say, let's try some traditional treatments first. And then if it's not getting better, I'll do the ultrasound. So the first visit, they're getting x-rays. And then usually the second visit at 2 weeks, they're getting an ultrasound if they're not responding to some of those treatments. The reason I'm saying that the ultrasound is a high profit is that based on the ultrasound, for example, I had a patient the other day. They came in and they had plantar fasciitis that was getting better at the follow-up, but I did an ultrasound then and I showed the bad foot comparing it to the good foot. That's the benefit, is you show the bad foot and the good foot. You show that the fascia is thicker. There's effusions in there. And he said, even though it's feeling better, I do see the difference in the tissue and I want to do the Shockwave. So it's the best seller of Shockwave is the ultrasound. I could not do as much Shockwave if I didn't have the ultrasound. So I'm a big advocate for ultrasound. Even if, let's say, you weren't charging for it and you just wanted to add it on, it would be worth it because so many more patients do the EPAD. Also, based on the ultrasound, if there is an effusion in that area, that's where I say, that's where the amnio, and then we're going to get to that next, is the next high profit procedure. But ultrasound in general, we didn't have it in the beginning, but we only had x-rays. But I found it's made me do much fewer MRIs, and it's much easier to do it right here in the office. It takes a little practice to do it, to learn the anatomy. What I did is I talked to our medical library at the hospital and I had them get a couple of there's some PDFs that talk about like musculoskeletal imaging with ultrasound, and they send those in PDFs to me. If you want them, just reach out to me. I can send you them. They're in PDF. I just can't publish them because they're from the hospital. But that's how I looked at those, and then basically you just practice on everyone. That's the best way to learn. One of the keys when you're doing ultrasound is to learn how to document. I find that documenting can be a challenge. So you have to learn how to do like, you always hold the probe in the same direction. So proximal, distal, medial, lateral, where that little dot is. And then we also use ultrasound for doing ultrasound guided injections. Okay, so that is how we use the ultrasound. Works very well. And the third high profit procedure I want to talk about is amnio. I think I'm going to stop at this one for this week. We'll go over the other ones the following week. So amnio, we use an amniotic, they call it stem cell. I tend to call it amniotic, like placenta, that we take that, and I explained it's donating to mothers. So the way I kind of explain it to patients is that Shockwave is used to increase their own blood flow to the area, or stem cells or healing cells. And then I say the amnio takes it from someone else. We used to do PRP, but amnio is a lot easier than drawing up the PRP. And I think it's a little bit more effective, but mostly it's just a lot easier. We do that, we had a small centrifuge and we did PRP, but we don't do that anymore. We just do the amnio. If I see something on the ultrasound, like a focal area of effusion, that's where I'll say, what the amnio does is it's kind of like Miracle-Gro on your lawn, right? It just speeds up the healing even more. It kind of is taking the EPAT and putting it on steroids. Very rarely do I do amnio by itself. I want to be clear. Very rarely do I do amnio by itself. I usually do it in conjunction with the EPAT. And I'll do it usually at the second session of EPAT, or if they come back for the second round, it would be the fifth session out of the sixth. Why do I do it that way? The first session, they just get used to the EPAT. Second session, I like to do it, and I always do the EPAT first, and then with ultrasound guidance, I put the amnio in, and also my patients get a cam boot that day. So when you're talking about high profit procedures, I put them in a cam boot for a week to rest it, because I say it's liquid gold going into their foot. So I like them to rest it with the amnio that goes in there. And I find that it potentiates the healing. It's not quick. So none of these are quick. So EPAT, amnio, I always have people get their expectations on correctly, is that it's going to take 6 weeks to start working, and then it's going to work for 3 to 6 months afterwards. And when I finish the third session, I say, over the next 6 weeks, what you're going to find is you're going to start to have more good days than bad days. Many patients come in, they say, well, I'm still in pain. I thought it was going to be 100% better, but I want to be clear. If they're still having pain, that's normal, as long as they're having more good periods of time or more good days than bad days. And then at their follow-up, at the 6-week follow-up, what I tend to say is if you're 50% better or less, I may do another round. If you're 80 to 90%, I'm probably not going to do another round of EPAT for the patients. So those are some high profit procedures. I'm going to talk about DME products, and in one of the following ones, we're going to talk about high profit DME products that go in conjunction with this, which is the AeroSpring brace. I'm not going to talk about that right now, but since this is getting a little bit long, I'm not going to continue with the others. We talked first 3 about were EPAT, ultrasound, and amnio. What I'm going to talk about next week are Cariflex, Onifix, and then nail procedures, and then some other types of procedures in the office. Okay. Once again, if you guys found this beneficial, please join the weekly update. All of this can be found in the Podiatry Practice Mastery membership as well. That's where kind of all these details are. If you guys enjoyed this, talk to you next week. Thanks.